project funded by the Patient Centers Outcome Research Institute, PCORI, to disseminate findings from several large, recently completed studies related to new approaches to dialysis care. Welcome to the webinar presentation today for ESRD network staff that's going to describe an advanced care training program developed for dialysis social workers. Let me please introduce today's two speakers. Jenny Kitsen has over 47 years of experience in the field of ESRD. She started as a medical social worker at Yale New Haven Hospital and was a member of the original dialysis and transplant team there for 10 years. For the next 35 years, she served as the executive director of the ESRD network of New England that covered 6 states. She served on several national ESRD task forces, nonprofit boards, and she founded the CT Donate Life Coalition. Currently, she's retired, and recently she's participated in 3 different stakeholder committees that involve patient empowerment and end-of-life studies. Her personal recent experience of being the only family support member for her older brother who was on dialysis for 6 years in a nursing home before he died has contributed to her strong commitment of advocating for shared decision-making and respect for patient choice in their life goals. Our second speaker, Dr. Joan Berzoff, is a professor emerita at the Smith College School for Social Work, where she co-chaired the doctoral program and directed the end-of-life certificate program. She has written and co-authored 4 books on end-of-life in multicultural settings. She has been awarded the Outstanding Teacher Award from NASW, the Outstanding Writing Award from the Association for Psychoanalytic Social Work, and she received a Social Work Leadership Award from the Project on Death in America. She teaches in the doctoral program at the Institute for Clinical Social Work in Chicago, and she's in private practice in Northampton, Massachusetts. As usual, for attending this webinar, 1 continuing education credit is available to all nurse and social work attendees who've pre-registered and who attend today's event, including filling out the evaluation form at the end. If you're joining by phone only, please send your phone number to Heather at hcecil@nw5.esrd.net. Again, that's hcecil@nw5.esrd.net, so she can verify your attendance for continuing education credit. These will be mailed to each attendee who meets our requirements within 1 month of this event, and the certificates will be mailed to the email address that you provided during registration. Finally, please post any questions that you have during the presentation using the Q&A icon at the bottom of your screen, and we'll try to get to as many of them as possible. Now, I'm delighted to turn it over to Ms. Kitsen and Dr. Berzoff.
All right. Well, welcome, and we're very glad to be together on this day. So we're going to do 4 things today. Oh, can we change the slide, please? And those include describing some of the current issues in renal social work, advanced care planning. Then we want to talk about the educational content that we developed for social workers to enable them to take more leadership in advanced care planning. We want to talk to you about some of the unexpected challenges that we encountered. And finally, we want to make some recommendations for training renal and palliative care social workers. So, Jenny, next slide.
Yes. Next slide, please. Okay, let's begin by just reviewing very briefly what we know. There has been remarkable advances in medical knowledge and technology, and individuals are living longer with better coordination of complex chronic diseases. The end-stage renal disease program can be considered a huge success, and at the same time, the current situation is a bit distressing. There are approximately 600,000 individuals on dialysis in this country. The 5-year mortality rate is approximately 35%. The largest increase in new patients starting on dialysis are in the age group of over 70 years old. Many of these patients are frail with high morbidity burden and have a little to no family support. 49 of these elderly long-term hemodialysis patients spend time during the last month of their life in an intensive care unit, compared to approximately 24% of cancer patients. A recent study noted that less than 10% of end-stage renal disease patients report having a conversation about end-of-life issues with their nephrologist in the previous year, even though patients indicate that such conversations are important to them. We need to find better ways to have these difficult conversations about patient life goals and end-of-life management. So let's start with a polling question. Next slide. Although dialysis is a life-saving for patients with kidney failure, approximately what proportion of patients do you think die in the first year? I'm in a situation where I can't see the responses, so Joan, if you could give me some kind of an idea when you see
seeing them either, which is kind of odd. Yeah, I'm not seeing anything come up. Ah, now I am. Okay, so we have 15% of our audience saying, answering B, and we have 25% answering C and 45% answering D.
Wow. It looks as though from your perspective as social workers, you feel there's an incredibly high proportion of patients dying in the first year. Actually, the overall rate, according to the data in the renal registry, is that it's 25% in the first year. However, if you stratify this data, consider that 49% of patients with 4 or more comorbidity conditions are dying. We have 45% are entering into the system with 4 or more chronic comorbid conditions. Of that group, 26% are dying within the first 30 days of starting on dialysis, and 60% are ending up dying within the first year. So when you stratify it, in some ways, you're probably thinking about the frail chronic patients that you observe as they're entering the program, as opposed to the overall number of the patients, which is about 25%. Okay, that's interesting. All right, let's go on to the next slide, please. We want to begin by telling you a little bit about the study in general and how it was set up. It's a 3-year study that was started in 2014 and recently completed. It was called Shared Decision Making and Renal Supportive Care. It was funded by the Patient-Centered Outcomes Research Institute, which is PCORI, which was established under the Accountable Care Act to address disparities in healthcare. The approach of this kind of grant is to have more community-based research, and patients and stakeholders are engaged in the actual design and the implementation of the study. Our particular project, we had 18 dialysis clinics divided between New Mexico and Western Massachusetts. There was also involved 3 IRBs, medical review boards, so you can imagine the complexity of getting everybody to agree to the design of the study. University of New Mexico Medical School, Bay State Medical Center, and Northeastern University, which was responsible for handling the data analysis. Our overarching goals with this study were to increase advanced care planning and hospice referral. The study design was to have the dialysis social worker take the lead in the conversations and advanced care planning process. So let's try another polling question about hospice. Can you go to the next slide? Okay, ESRD patients carry a prognosis similar to cancer, and 55% of cancer patients are referred to hospice care. What percent of dialysis patients do you think are referred to hospice?
All right. So the responses tell us that let's see, 86% of you think 20% are referred to hospice. 8% of you think 33% are referred to hospice. And 4% of you say that none are referred to hospice.
Well, you're right on in terms of the majority. The data is 20%, which is, as you can see from the information we're providing, so much lower than what is observed when working with cancer patients. Even though we all know that the conditions of coverage require the dialysis clinics to inform patients about the fact that they have the right to execute an advance directive and have information about end of life, it seems as though what we're observing is many times these forms are given to the patient, but there is very little time for follow-through or conversation around these particular topics. So let's go on to the study and show you what we learned with regards to working with patients and addressing end-of-life care. Next slide. Okay, thank you. This is the patient sample in terms of how we set up the project. We were able to recruit 125 patients and families from two geographic areas, Massachusetts and New Mexico, as we mentioned. And patient-specific data was obtained on all of these patients in the study clinics. An analysis on the patient population was done using a validated prognostic tool that contained elements such as the patient's age, low albumin levels, the presence of peripheral vascular disease, the absence of dementia, and the response by a physician to a surprise question. Would you be surprised if this patient dies within the next 6 months? If the response was no, then this patient was considered in the risk of high pool along with the other criteria that was used to identify patients that were at risk. To participate in the study, the research team was able to get 125 of these high-risk patients to concur to participate. Because of the geographic location of the two research centers, the population diversity also added another cultural and economic aspect to the study. Massachusetts, where there were predominantly white, Puerto Rican, and African American patients, and in New Mexico, where there were mostly Mexican and Native Americans. Also, these patients, when they consented, were asked if they were willing to know what their prognosis was, and most of them said they were interested in getting further information. Okay, next slide.
Okay. 17, as we said, social workers were recruited to take leadership in advanced care planning. As we said, there were 18 dialysis clinics. Social workers had the task of facilitating the process of sharing prognosis along with the nephrologist, and then developing individual and family plans, and finally following patients along the disease trajectory. So advanced care planning began really with the sharing of prognosis, and then the development of a plan, and then a follow-up. So why were social workers chosen? The research team felt that they had the greatest amount of biopsychosocial knowledge. Therefore, they could address spiritual, cultural, psychological issues, and because they were in close contact with the patients. Another polling question. In my dialysis clinic with my patients, we usually discuss hospice care, voluntary withdrawal from dialysis, assigning a healthcare proxy for end-of-life decisions, preference for place of death, hospital or home, choice of life-sustaining treatment at the end of life, completing the living will. None of these issues are discussed. All right, so the results show that 62% of you discuss hospice care, 69% of you discuss voluntary withdrawal from dialysis, 76% of you talk about assigning a healthcare proxy for end-of-life choices, 19% of you talk about where the patient and family wishes for the death to take place. 69% of you talk about life-sustaining treatments or not at the end of life. And 76% of you, of course, discuss completing a living will. So these are tasks for advanced care planning. And so there are about 25% of you that don't do these things. And that's interesting because what we found and what the literature has cited is that many renal patients and their families know very little about advanced care planning. And many fear discussing end-of-life care issues with their nephrologists. Patients, family.
Hi.
Sorry, what?
I was just going to say, maybe you need the next slide because you're talking.
Oh, I'm sorry. I am so sorry. May, the next slide. All right. All right. Patients and families also avoid difficult conversations, but so do staff, and that includes nephrologists, and that includes social workers. And so there is a reluctance to talk about the end of life. Another problem in having these conversations and having them be executed coherently is many of these patients, particularly those who are elderly, have a complicated trajectory of comorbid conditions. And that also gets in the way of end-of-life care planning. So another piece that erodes trust and a sense of communication, easy communication, has to do with unexamined spiritual and cultural beliefs that patients and families may have, and also that staff, i.e. nephrologists and social workers, may have. And so those may get in the way between patients and caregivers. Of course, educationally, we found that social workers are simply not supported to do end-of-life care planning in their schools for social work. For example, there was a study of 375 social workers, nurses, and nephrologists, and 83% of them reported that end-of-life care planning or advanced care planning occurred ad hoc, meaning at the moment. And 82% of nephrologists, social workers, and nurses reported that there was a lack of clinical expertise to have these kinds of conversations. 82% reported increased competition for their time that got in the way of having these kinds of conversations. And 95%, almost the entire sample, said that they needed more education on advanced care planning in their clinics because they had not had sufficient training. So that's an interesting thing to know. Okay, next slide, please. Also, an impediment to making advanced care planning coherent is that there are constant changes in life goals. For example, as comorbid conditions worsen, advanced care planning gets complicated by the disease trajectory itself. Often, and it seems like only 25% of you don't introduce patients to living wills, surrogate decision-making, or information about life-sustaining treatment. And again, there are major cultural differences around such issues as truth-telling. Do we tell a patient their prognosis, or do we tell a member of the family the prognosis and shield the patient from the prognosis? Or do we not tell truth at all? End-of-life conversations are also hard on us, the practitioners. This is really difficult stuff. And so talking about death, planning for death, dealing with the major feelings that occur around death with family members and patients That takes a lot of knowledge and skill, and also a lot of self-knowledge, which we will talk about in a minute. Okay, next slide, please. So, oh, another polling question. Okay, in your experience at your dialysis clinic, which of the following would be the greatest barriers to advanced care planning in your opinion? Only pick two, please.
Huh.
Oh, okay, and the results are 25% of you said despite training, guidance documents, and other resources and materials, that you don't feel truly prepared to have such discussions with patients. And that's an interesting finding. 5% of you cited the high rates of social work turnover. 68% of you talked about what we encountered as well, which is how difficult it is to schedule time to talk in depth with one patient and fitting in a family member's schedule, and I might add the nephrologist schedule and the social worker schedule. So that's a big barrier. 62% of you identified that while dialysis sessions may not be the best time for end-of-life discussions, patients often don't want to make additional trips for separate meetings. So that leads to some problematic issues in terms of involving family. And then 38% of you said that for the majority of patients who participate without a family member or surrogate, portability of documents across healthcare systems is a large challenge, and it is. So let's talk about that. All right, next slide, please. Whoops, what happened to our barriers slide? Yeah, thank you. Okay, what the literature tells us and what we all know is that time is in very short supply. The social worker's time, the patient's time, the family's time. And we also know that there is a lack of integrated advanced care planning between healthcare providers. So, for example, many patients end up in nursing homes or ERs or ICUs or inpatient facilities. And at that point, due to HIPAA regulations, it's very difficult to make healthcare documents portable. And so the communication breaks down between systems. And of course, where our focus was really located was that social workers and nephrologists really haven't been trained in renal palliative care. Sometimes social workers have attended postmaster's training programs, but in our master's programs, there is a scant attention to end-of-life issues, like 4% of the curriculum, 2 to 4% of the curriculum actually involves end-of-life issues, which is pretty horrifying. Next slide, please. So what do social workers need to know? Well, lots of things, but in a study by Weisenfluh and Sekai, what they identified as the highest priorities in terms of advanced care planning was social workers wanted to know about individuals and families, about cultural differences, and wanted to improve their skills in intervening with teams. Next slide, please. But we wanted to know what these particular social workers wanted to know as well, and we wanted input not only from them, but also from patient advisory boards. And so we had focus groups with 2 patient advisory boards, focus groups with all of the social workers in New England. We met individually with the social workers in New Mexico. We had focus groups with nephrologists. And out of all of that data, we culled the following goals, which is social workers need to become better advocates for patients within the organizational culture. Social workers need training to become more adept at cultural and spiritual issues. Social workers need to have more knowledge about legal and ethical issues, living wills, advanced care directives, surrogacy, conflicts of interest. Social workers need to know how to break bad news while also conveying hope. Social workers indeed wanted to learn more about working with individuals and families. They also wanted to become more adept at examining their own feelings, their own countertransference responses to dealing with death and dying, their own resistances to bringing up issues around death and dying. They wanted ways to talk about and deal with their own compassion fatigue and their own burnout. And finally, they wanted a way to more efficiently and effectively assess what are the structural barriers in my organization and on my team that get in the way of providing quality advanced care planning in nephrology. Next slide, please. So, in response to all of this input, we developed a training program. It had really 2 parts. One was an 8-hour didactic, that means teaching experience, that was held by video conferencing for all 17 social workers across New England and New Mexico. We enlisted a faculty with whom we worked and prepared for this, and that faculty included a palliative care doctor, 5 social workers, and a lawyer. The 5 social workers were trained in end-of-life care that had to do with clinical practice, with leadership, and included us. So there were 4 training modules that we developed. One was about clinical practice and really included issues of communicating bad news, countertransference. Another was around developing leadership skills, a third on cultural and spiritual issues, and a 4th on legal and ethical issues. We also, as a faculty, spent a lot of time creating case studies that were really designed to illustrate the key teaching points that we developed and to integrate what we were teaching theoretically into direct practice. When we would do a case example, we would not be on the long distance video conferencing, and we would break up into small groups. So some of our faculty were in New Mexico, some of our faculty were in New England, and we would break up and discuss the clinical examples in some depth. All right, next slide, please. Jenny's going to talk a bit about the curriculum.
Okay, yes, a little bit more detail about the modules that we worked with. We did, as the members of the team, the study team actually developed a video that demonstrated and offered a guide for the intervention discussion for the patient meeting and family meeting that the social worker would have with a nephrologist, illustrating the social worker in the lead role and the nephrologist being present and engaged in the conversation, providing the clinical information and offering prognosis information, but not leading the discussion. That was kept to the social worker. And you can see there, it's on YouTube and the website is there. And we had a template in terms of what written out as well as to what the social workers could use and modify as needed depending on the discussion and who was in the room doing the intervention conversation. The key points of the intervention meeting was to stress and evaluate the patient's current knowledge of their illness, explore expectations of their future medical status, identify life goals and tasks of importance that needed to be addressed, share end-of-life resources, and use the teach-back technique to confirm that exactly what did the patient hear and what did the patient understand, and then lay out the next steps in terms of what the social worker would do in terms of following up with the patient. The social workers were also encouraged during this training session to discuss their own particular comfort level with these difficult conversations and trying to figure out how to come up with the proper words for breaking bad news, because all of this is so emotionally stressful and difficult to do. During this training session, they shared their own experiences and talked about some of their own resistance. Handling compassion, fatigue, and burnout is a constant challenge, particularly if you've been working in this field for a long time. I think sometimes you may learn how to handle it, but as time goes on, you see so many of these cases that you begin to wonder, how can you be more effective? Members of the team also frequently come to the social worker to seek emotional support for their own personal issues that they have, because they have come to know these patients and caring for these patients for so many years, and then when they begin to see them deteriorating in their care, I think the team as well has stress and emotional connections that have to be sorted out and worked with as well, and they turn to the social worker for that sort of help. So frequently I think that and what we observed is that the team tries to set medical and life adjustment goals that the team can control, but sometimes ignores the conversation about what is purely emotional and beyond their control. So next slide. As Joan mentioned, frequently we ignore or minimize the cultural and spiritual issues that take place or that are of importance to a patient. One of the tools that we did use is, the acronym is FICA, and that's definitely not a tax form. It really does mean something. F stands for faith. Do you follow a particular spiritual belief? That helps to get into that conversation. I stands for important. Are these beliefs important to you? C stands for community. Are you active in a religious community, a church community, a center that you might go to? Helps also for you to understand some of the social dynamics of that patient and what is meaningful to them. And A stands for address. How can we help address these issues with you based on what you've identified from that conversation? We can never make assumptions about people based on their culture and their faith. What gives a person a sense of purpose and meaning in their life is often unique. We know we must be good listeners. We need to understand these cultural beliefs to show and respect and gain the trust of the individual patients. It is important for all of us to do our homework based on our own patient population and geographic area where you are, to try to understand what are some of the power imbalances that take place because of the racial diversity that you might have in your geographic area. Learn how to bridge some of these cultural divides that might exist within your clinic, and work through and understand and help your team as well to be better sensitive to some of these needs that the patients are dealing with in their own ethnicity. Next slide. So, legal and ethical issues. We did have a lawyer who reviewed the ethical principles of benevolence, desire to do what is best for the patient. We discussed autonomy, the right of an individual has to exercise control over their own body and to make medical decisions, including refusal of unwanted medical care. She also reviewed for us specific laws regarding New Mexico as well as Massachusetts related to end-of-life decisions and the capacity to make decisions, the decisional capacity of a patient to be able to make his own particular decisions. These are important tasks that you should look into and make sure that you understand, again, based on your geographic area and the states that you are particularly working in. Next slide. Okay, leadership in the organization. Okay, the ability of the social worker to take a leadership role within the dialysis team frequently depends on the culture of the clinic and often is set by the skill level of the team and/or by corporation policy. Also, the experience and skills demonstrated by the individual social worker will help assure and gain respect of other team members. Conflict resolution, negotiating techniques, communication skills are frequently needed to self-advocate your own particular unique role and the services that you can provide within that particular clinic. And some of these structural barriers can be huge, and in addition to just working with a multidisciplinary team within your clinic, you also frequently have the challenges of multiple nephrologists who are rotating through, who might also have different philosophies and different ideas about how you as a social worker should be interacting and serving your capacity within that particular team. So it would be helpful, and it may be time-consuming, but you might be able to gain a lot of insight if you were to have a special private conversation with the medical director. We found that when we did our training, the physicians were trained separately from the social workers, and so many of the social workers said, no, please, if you're doing this model going forward, consider having an integrated training session with the nephrologist. Even though time is an issue, it's important with the nephrologist and the social workers together at the same time. Some component of that should be addressed. Okay. Next slide. Supervision groups. Joan and I conducted supervision groups, which were really very challenging to do when you consider the time zones, New Mexico and New England. We did 2 per year, so and it was a 3-year study, so we were trying to evaluate and assess where the social workers were at, and because it was a staggered kind of integration into the program, not all clinics started at the same time, so we were trying to work our way into having shared experiences as best as possible and learning over a spectrum of the 3-year study. The sessions were often a mix of peer support, also sharing some challenging cases, some that we presented and some that they brought forward. The social workers would offer feedback to us on the intervention protocol and the template that we had designed. It became modified as we went through the program. And the topic of patient readiness to hear bad news was, and the challenge of not taking away patients' hope to live became a frequent topic of discussion. That delicate balance, trying to maintain hope and to give patients courage to continue to comply with their treatment regime while still being realistic with perhaps their deteriorating health and their clinical situation, was extremely stressful and complex, I think, for many of the social workers as they were working through these discussions with their patients. Joan and I also did a few one-on-one consults with individual social workers regarding some of their more difficult cases. They could seek us out, and we would have a conference call around those particular subjects. Okay, next slide.
So as I listen to all this, it sounds so easy. Offer a curriculum, give a didactic training, provide supervision groups. But in fact, it wasn't easy, and there were many complications and many challenges that we encountered. For example, we had a high percentage of turnover among the social workers. So we started with 17, and we had, by the end, we ultimately had to train 23 social workers. So that means, and 1 nurse manager, which was really problematic because we weren't, the protocol was not to train nurses at all. But there was no social worker, so we had no alternative. Plus, how does one train 6 people in the content around legal and ethical issues, cultural and spiritual issues, practice, and leadership without an 8-hour training? And so it was very ungainly and very really difficult to then provide training to the people who joined later on. And also kind of a large loss to have trained 6 people who left. So that in and of itself was a problem, and an unanticipated one. I think we might have anticipated there was going to be a very, very large range of social work experience. So in New England, for example, we had social workers who had worked for a mean of about 9 years in end-stage renal disease. In New Mexico, it was much lower. Also, there were big regional differences in terms of how social workers saw themselves. And the New England social workers felt that they already were leaders and had, by and large, good relationships with their nephrologists, in part because they had been a part of a number of studies like this one, in which they developed strong relationships with their nephrologists and were respected in their clinics by their nephrologists. Not so in New Mexico, where, again, many people came in with less experience, much greater turnover of nephrologists as well in New Mexico, and often a situation in which nephrologists were constantly rotating. Another major difference was that in New England, social workers met monthly to provide each other peer support. In New Mexico, social workers, many of them had never met one another. And so they had very little staff support from other social workers and lacked any sense of social work cohesion. I might add that many of the New Mexico social workers were working in rural settings. So they could be as far as 8 hours away from large cities where other social workers were. All of the social workers had very, very high caseloads, and I'm sure you can resonate with that. There were, among the social workers, many barriers to, again, providing anything close to a cohesive advanced care plan as patients moved in and out of nursing homes, ICUs, and other inpatient settings. So those were some of our training challenges and their training challenges, but what did the social workers want? Next slide, please. As we asked the social workers, okay, so, we tried this kind of training. What was helpful, what wasn't? And it was clear that social workers across the board wanted more opportunities to process their difficult feelings doing this work, whether in peer supervision, whether in group meetings, whether in formal coursework. Social workers also wanted, as Jenny said, the opportunity to discuss this core issue of how do we talk about advanced care planning and end-of-life decision-making while not taking away hope. And so how do you balance hope with prognosis and with reality was such a key issue, and social workers wanted a place to talk about that in a consistent way. Social workers also wanted a place and found value in talking about not only self-care and burnout, but also their own countertransference feelings. What does this bring up in terms of one's own losses, in terms of one's feeling that one may be intruding upon patients and families, that one may be bringing one's own agenda to the table? How do social workers deal with their feelings around advanced care planning? Social workers also reminded us that there's no place in which they get trained around the biology of end-stage renal disease, and that if they're going to be leaders, that they need more information and more knowledge about biological issues. For example, they need to know about the disease trajectory, and they need to know about prognosis making and how that is done. As Jenny said, they were adamant and very clear that if they were going to be trained, damn, their nephrologists needed more training than the 1-hour training that was being provided in this grant around breaking bad news, which was provided for the nephrologists. So the social workers were clear that they would want their nephrologists to be involved with them in advanced care planning training, and particularly in practicing a model of breaking bad news together as part of that training. So the social workers in our study saw themselves as highly competent on cultural and spiritual issues. We weren't so sure that everybody was as competent as they thought they were, but nonetheless, they noted that there were not many moments in which they were called to reflect on themselves, and that they needed more places and more time for ongoing self-reflection. That was really crucial to doing this work. Next slide, please. So what did we learn? Well, we learned, of course, not unexpectedly, that end-of-life care knowledge is limited among renal social workers, and that social workers would like greater opportunities for self-reflection, to look at legal and ethical issues, to examine diversity issues in cultural and spiritual domains. We learned somewhat painfully that an 8-hour training program is probably not realistic, given the time and economic resource constraints that social workers face in their agencies and in their clinics. We learned unexpectedly, but nonetheless importantly, that there are really regional differences in knowledge and skills, and that patients and families do receive different levels of care. And we learned that corporate management really needs to support advanced care education, no matter what the region or level of experience. So, there had been a study that we had used of 187 social workers, in which only 4.5% felt that they were providing quality, supportive, end-of-life care. And that's a pretty damning statistic. And so it's clear that we need to be able to support social workers and nephrologists in providing quality, supportive care at the end of life. Next slide, please. And of course, there are other structural barriers. Again, almost all of the social workers cited lacking time for really appropriate end-of-life care planning with patients, in which they could not only have difficult conversations, but then systematically follow up with patients as they moved along the disease trajectory. The social workers in our study were critical of the business model that really governs care, and often leads to following the letter of the law. That is, social workers would give out information, give out materials on advanced care planning, but often the spirit of advanced care planning was not followed, which is to have difficult conversations and to follow up with patients and families along the disease process. Again, we keep going back to, and they noted, and we noted, the lack of coordination across multiple providers. So again, if a patient ends up in an emergency room, in an ICU, in a nursing home, there often is a lot of fragmentation of care. And so, part of the problem is there's a HIPAA regulation that information can't be shared between these different settings, but that really leads to a fragmentation of any coordination of care and the ability to really follow patient and family wishes. What we noted and what social workers noted was that the culture of end-stage renal disease can be quite corporate, and one in which the role of social worker as leader is not acknowledged in advanced care planning. And again, social workers pointed to the discomfort of some of the nephrologists in terms of having conversations about prognosis. Next slide, please. So what do we recommend? Well, we recommend that palliative care be acknowledged as a area for renal social workers, and that this be acknowledged at the corporate level, that this be acknowledged in terms of advanced care planning teams, and that social workers also be able to acknowledge themselves as leaders and be able to step up to the plate. We thought it's really important, just pragmatically, for social workers to be encouraged to form peer support learning groups in which they can talk about the kinds of things we're talking about now, balancing hope with reality, exploring their own feelings and resistances to dealing with end-of-life care discussions, talking about cultural and spiritual issues among their patients and themselves, peer groups in which they could share resources, deal with some of the legal and ethical issues that come up, and work to differentiate their own personal wishes at the end of life from those of their patients. What we also recommend is that there be the space and time for self-reflection. It's key to doing this work, and that social workers be helped to advocate for more training and also more realistic caseloads. Next slide, please. So we also recommend that end-of-life care training needs to occur routinely at the master's program, at the clinical level in clinics, and at the corporate level. This is really important for patients, for renal patients who are dying. So training needs to come with a corporate commitment to working with social workers. And we thought at the beginning of their careers, so that social workers could receive ongoing advanced care planning training, not only at the beginning of their careers routinely, but also that this training needs to be incorporated at regional and national meetings. Next slide, please. So we would offer that important content remains the legal and ethical issues, the cultural and spiritual issues, countertransference issues, knowledge of the disease trajectory, and ways of talking about taking leadership in interprofessional work. All of this content needs to appear at regional meetings and national meetings. Again, social workers can and should develop their own peer support groups, but they also need didactic training to learn how to become leaders. And then, of course, social work schools have to pick up the mantle of providing palliative care education to all students, since there are two universals we can count on in this world. And one is that we will be all born and we will all die. So if 100% of us are going to die, then social work schools need to begin to talk about dying routinely as core knowledge in social work education. So again, what we really have to say is that we think social workers at the beginning of their careers need to be introduced to advanced care planning in their clinics, and that training needs to continue in short lectures, in written resources that would include biological issues, spiritual issues, cultural issues, organizational issues, legal issues, ethical issues, and most of all, clinical issues as they emerge. So why don't we stop there and ask you to send us questions, which we will hope to answer as best we can. So I see that there are 3 questions and answers. Let us give you a few minutes to write some questions, and then we'll take them. All right, so take a minute or 2 if you have questions and write them down.
Joan, I see we're beginning to get close to the end of the hour. Maybe we can take the,
all right, why don't we take the 3 that we okay. All right, so one question comes from someone who says, even though the discussion has taken place, the advance directive is not returned to us. So, Jenny?
Personally, I find it amazing.
Yeah.
And I would deal with that as a policy issue within that particular clinic. You know, if you're involved in doing the planning, you need to know exactly what the directive is saying, and I would hope that there would be some way of communicating. That's a serious breakdown in communication.
Yeah. I'm going to go to question 3 because it's something that we encountered so often. Suppose patients and caregivers have different priorities. Well, that's a really important clinical issue because often patients and caregivers do have different priorities. As we said, often families may want to keep their family member alive at any cost, and patients may feel differently. Often patients want to shield, families want to shield patients from the inevitability of their deaths. Often patients want to know the truth. So there are very often conflicts between patients and families, and those have to be navigated and they have to be held, and patients need often help articulating that their priorities at the end of life may be different than those of the family. Jenny, do you have something to say about that?
Well, also, I think in a couple of the cases that we experienced, it came up frequently, but one of the solutions we discovered was sometimes to take the spouse or the family member who is being the obstructionist or perhaps unreasonable aside and try to have a one-on-one conversation with them to allow them to vent. There may be secondary issues that are going on behind the scenes that you are not aware of and not familiar with, and sometimes giving them the opportunity to fully express themselves, not in front of the other family members and not in front of their loved one, can help you figure out a better way to sort of navigate the conversation and move on from there. You don't know what some people have in terms of other agendas or anger issues that just need to be explored separately.
All right, so we have two questions that really dovetail with each other, and maybe these will be the last questions. What do you think, May?
Yes, I think that would be perfect.
Okay, so the last questions are clumped around how do we provide access to some of the training that you provided, and is there an online certificate program of advanced directives, and is there an end-of-life program? So I'll take the second one first, which is there are online certificates in end-of-life care training. They're not specific to renal palliative care, but they are extremely useful. And if you Google them, you will find them. There are also live in-person end-of-life care training programs. Postmasters, NYU has one, Smith has one. So there are both, and so you should Google those. In terms of accessing some of the training that we provided, Jenny?
Well, there is the video, for one thing, that we noted during the conversation, and we are in the process of writing up articles to be published on this material, and you have references provided for you in the background at the end of the slide presentation that can lead you to other places. And I might recommend to you the Coalition for Supportive Care of Kidney Patients. The website is kidneysupportivecare.org. They have some information there that might be of use to you in terms of materials and how to engage patients and talk to them. So right now we don't have what I would call a manual, right, Joan?
Right, we do. But
But
we certainly do, yes, in our references, we have a number of places that will teach you and train you, articles and so forth in all of these issues, because they were the articles and training programs that we relied on in terms of developing our training program. So I think we should stop here and thank you all for your involvement and interest, and hope that this has been helpful to you.
Yes, thank you so much.
Thank you both so much. This was a wonderful presentation, and I hope everybody learned a lot from it. And if you have any questions, you can send them to us. We will pass them on to Joan and Jenny. And there is, as I said, there's a lot of references to the material and a YouTube video that they have in this webinar. And we will also send it out if anyone's interested in seeing the slides. Please, I'll get off very quickly. When you exit, as usual, hit the continue button that takes you to the evaluation form. Please, it's a very short form. Please fill it out so you can get your CE credit. And stay tuned. We're going to have follow-ups on all of the different research studies that we presented to you this fall and winter next year, and we'll let you know. Again, thank you all, and have a wonderful holiday at the end of the year.
Thank you. Okay. Okay. Okay.